of the more specialized blood collection techniques is the collection of arterial and capillary specimens for blood gas analysis, performed by respiratory therapists, phlebotomists, and other healthcare personnel. Blood gas results provide physicians with meaningful information about the respiratory and metabolic status of their patients. Because a puncture to an artery or arterialized capillary bed is required, this procedure demands extensive training, knowledge, and skill on the part of the collector. In this video, we will discuss proper arterial and capillary blood gas collections according to the clinical practice guidelines of the American Association for Respiratory Care, AARC, and the standards established by CLSI, the Clinical and Laboratory Standards Institute. With the information presented here, you will be able to demonstrate the proper procedure for safely obtaining arterial and capillary blood specimens, describe the complications commonly associated with arterial collections, and prevent collection and transportation errors that can alter test results. Performing arterial and capillary punctures requires comprehensive training, which should include detailed instruction on respiratory physiology, anatomy, site selection and preparation, pre-analytical errors, and the risks associated with such collections. Collectors should follow standard precautions throughout the sampling and handling of blood gas specimens as prescribed by their institution's policy.
Many of the patients that have need for blood gases usually are in intensive care units, and this information will allow the physician to actually treat an imbalance either in what we call respiratory or metabolic alkalosis, acidosis related to pH, related to the oxygen content, carrying capacity of the blood, and related to the carbon dioxide release and uptake. The patient, if it's related to respiratory, then the patient and is on a respirator, the patient can indeed be manipulated so that they can either increase the amount of ventilatory capacity that is needed for that patient based on the blood gas analysis, or they can decrease it, or as you say, they can attempt to try to wean the patient by looking at multiple samples serially down the road with each change in the ventilator.
The three acceptable sites for arterial blood collections are the radial, brachial, and femoral arteries. Because of its location, the radial artery is the most frequently used. Its relative close proximity to the surface of the skin makes it easy to detect, access, and apply pressure to once the puncture is complete. Another benefit of this site is the collateral blood flow provided to the hand by the ulnar artery. To locate the radial artery, apply pressure using your index finger and locate a pulse. Typically, the radial artery lies close to the wrist in the depression between a tendon and radius of the lower forearm. Keep in mind that detecting a pulse may sometimes prove difficult, as with obese patients and patients experiencing low blood pressure or a weak pulse. Due to its depth and close proximity to nerves, the brachial artery should be considered as an alternative site only when neither radial artery can be confidently accessed. In such cases, evaluate the brachial artery in each arm to determine the best choice. In comparison to the radial artery, the brachial artery is larger and generally has a stronger pulse. However, disadvantages associated with the brachial artery include a lack of support by tendons and bone compared to the radial artery, the absence of collateral circulation, a higher risk of injury due to its close proximity to the median nerves, and an increased risk of hematoma formation due to its depth. The femoral artery may be used to obtain an arterial blood specimen when neither radial nor brachial access is an option, as during CPR. Located in the groin area of the leg, punctures to this site should only be performed by a physician or qualified emergency personnel trained in this procedure. According to the AARC guidelines and the CLSI standards, arterial punctures should not be performed on radial arteries where collateral circulation to the hand cannot be established, through lesions, infections, or distal to a shunt, or on patients with a coagulopathy or who are receiving medium to high dose anticoagulant therapy. In most instances, plastic preheparinized syringes are used for arterial blood sampling, pre-assembled with a 22 to 25 gauge needle. If not pre-assembled, prepare the needle and syringe according to the manufacturer's instructions. OSHA requires that gloves be worn for all vascular access procedures. Arterial blood for blood gas analysis should not be drawn with excessive aspiration because subatmospheric pressure may alter test results. Therefore, drawing into evacuated tubes may not be appropriate. Other supplies include alcohol preps, gauze, bandages, a sharps container, and gloves, preferably latex-free. Inpatients should be asked to state their name, address, unique identification number, and/or birth date. Compare the information given with the information on the requisition or pre-printed label, as well as with the patient's identification bracelet, which must be attached to their person. Outpatients should be asked to state their name, address, unique identification number, and/or birth date. Compare the information given with the information on the order and requisition. Resolve all discrepancies before drawing any patient. At a minimum, the requisition should include the following information: the patient's full name and location, a unique identification number, the birth date or age of the patient, the date, time, and site of the sampling, the fraction of inspired oxygen or the prescribed flow rate, if applicable, identification of the individual performing the collection, the ordering physician. If bracelets are missing or not attached, seek confirmation from a caregiver or family member and document the name of the verifier. The same holds true if patients are unable to communicate or are otherwise unable to identify themselves. Again, any discrepancy should be resolved and corrected prior to specimen collection. Explain to the patient what will occur in a reassuring manner. Attempt to calm anxious patients, since hyperventilation can temporarily alter blood gas levels. For patients receiving ventilator support or oxygen therapy, verify that the therapy has been constant for at least 20 minutes prior to collection. Patients on room air should sit or lie comfortably for 5 minutes prior to sampling or until breathing is stabilized. Although rare, an injury to the radial artery limiting circulation to the hand is conceivable. Prior to accessing the radial artery, verify that there is sufficient collateral circulation of blood through the ulnar artery that also supplies the hand. The most commonly performed method is the modified Allen test. Perform the test as follows. Instruct the patient to form a tight fist. Apply pressure at the wrist, constricting both the radial and ulnar arteries. Tell the patient to open his fist. If the palm and fingers remain pale in color, circulation has been successfully obstructed. Release pressure from the ulnar artery only and observe the palm. If the skin color returns to normal within 15 seconds, the Allen test is positive and you can proceed with the radial puncture. If the palm remains pale, the Allen test is negative and the radial artery should not be used for the procedure. For unconscious patients or those unable to cooperate, follow your facility's policies. If an acceptable radial site cannot be located, palpate for the brachial artery on the inside aspect of the upper arm. For radial draws, hyperextend the patient's wrist if possible to more securely position the artery closer to the skin's surface and to tighten the skin for easier needle insertion. For patients who are unconscious or cannot assist, hyperextension may be accomplished by positioning a rolled towel under the lower forearm. Cleanse the skin above the artery with alcohol or other appropriate antiseptic, according to your facility's policy. Allow the antiseptic to dry. If the syringe is vented, position the plunger to the desired volume. If not, expel the air according to the device manufacturer's recommendations. Place the gloved index finger of your free hand on the skin directly over the artery, applying light pressure so that the artery can be located but not occluded. Hold the syringe in your dominant hand like a dart between the thumb and index finger. Alert the patient to the impending puncture. With the bevel up, puncture the skin slightly distal to your finger at a 30 to 45 degree angle. Advance the needle into the artery. When entered, blood will spontaneously flow into the syringe. While filling, maintain precise needle placement. Observe for an uninterrupted flow into the syringe. Terminate the draw if a hematoma develops. Allow the syringe to fill until a sufficient sample has been obtained. Place a dry gauze pad over the puncture site, quickly withdraw the needle, and apply pressure. Immediately activate the needle's safety mechanism. Remove and discard the needle into a sharps container. Expel any air bubbles from the syringe according to the manufacturer's instructions. Cap the syringe and gently invert it to ensure thorough mixing of the blood and anticoagulant. If the artery is missed, needle relocation may be painful and harmful to the patient, especially if performed near the brachial artery. Follow your facility's policies in recovering a failed attempt, but never probe blindly, as such attempts risk injury and complications. If performing a brachial puncture, cleanse the site and anchor the artery from above and below the intended puncture site with the index and middle fingers. Insert the needle slowly and steadily at 45 degrees or less between the pulses felt by both fingers. When blood enters a syringe, stop advancing the needle and keep it in position until an adequate volume has been obtained. Apply firm pressure for a minimum of 3 to 5 minutes for radial punctures. For brachial draws, at least 5 minutes of pressure are required. Observe the puncture site long enough to be assured that bleeding has stopped both superficially and subcutaneously. If bleeding continues, reapply pressure for an additional 2 minutes and reassess. Continue this sequence until hemostasis is achieved. When bleeding has stopped, cover the puncture site with a pressure bandage. Assess the palm for appropriate coloration and report any abnormalities. Alert the physician or caregiver if hemostasis is prolonged. Document all relevant information on the patient's requisition form as required by your facility's policy, such as ventilator settings, oxygen therapy, and the results of the Allen test. Before leaving an inpatient or dismissing an outpatient, label the specimen according to facility policy. Specimens collected in plastic syringes should be transported to the testing facility at room temperature, preferably within 15 minutes, but no later than 30. Do not transport specimens drawn into plastic syringes on ice. Obtaining specimens from an arterial line can be a non-invasive alternative to performing an arterial puncture. However, care must be exercised not to contaminate the specimen with air or infusing fluids. Obtaining specimens from arterial lines should only be performed by those trained in the procedure. The nurse or respiratory therapist, if authorized, should withdraw 6 times the dead space volume of the line and discard, or save for reinfusing. Attach the heparinized syringe and slowly withdraw the plunger until an adequate volume is obtained. Some syringes will fill automatically. Remove, cap, and label the syringe. Upon completion, the line should be flushed and any infusion resumed. Avoid forceful pulling on the plunger of a syringe as it subjects the specimen to subatmospheric pressure and may alter test results.
If you're going to draw from an older individual who has, say, an A line in, then you will probably want, if the line is being heparinized, to draw at least a full tube full, which would be 7 to 10 mLs, and to discard that and then proceed to draw your sample. But we're getting away from using heparin flushes in our lines because of the potential morbidity to the patient, and using more saline flushes. And heparin is reserved only if there is indeed a clot that has formed at the end of the line.
With the exception of PO2 measurements, specimens from arterialized capillary beds may be useful substitutes for arterial blood when assessing acid-base balance and the adequacy of ventilation on patients without readily accessible arterial sites. When drawing capillary blood gases on newborns and infants up to 12 months of age, the recommended skin puncture sites are the medial and lateral, inner and outer, plantar surfaces of either heel. To prevent bone penetration, punctures to the sides of the heel must not exceed 2 millimeters. Punctures to the arch of the sole or the back of the heel must never be performed. For patients 1 year and older, the fleshy pads of the third and fourth fingers are the preferred sites. Because the thumb contains a pulse and its skin can be thick and calloused, it is not a recommended site. Avoid the second or index finger, as it is typically more sensitive than the other fingers and may also be calloused. Punctures to the fifth or pinky finger should not be considered due to the insufficient tissue depth and the potential for injury. Previously punctured sites, as well as sites that appear swollen, infected, or excessively bruised, should be avoided. Since the flesh on the pad is twice as thick as the flesh on the sides, puncture the pad of the fingertip rather than the sides. The puncture should be across the fingerprints rather than parallel to them to prevent blood from channeling away from the puncture site. Supplies include gauze, disinfectant, a skin puncture or incision device, warm compress or commercial heel warmer, heparinized capillary tube, a metal flea and magnet, a cap or other sealant, gloves, and a sharps container. Arterialize the capillary beds by pre-warming the site for 3 to 5 minutes using a warm compress or commercial warmer not to exceed 42 degrees Celsius.
The important thing to remember about drawing a capillary blood gas is that we want to pre-warm the site so that we get a good flow of blood through the capillary beds. We want a good mixture of blood from the arterioles, the venules, and the capillaries to render a test result that accurately reflects the patient's physiology. And when we do that, we minimize the potential for us to have to excessively squeeze the site, which can introduce contaminants in the form of tissue fluid and can also hemolyze the specimen. Therefore, we want to pre-warm the site to get a good blood flow and a good, accurate test result.
Thoroughly cleanse the site with an appropriate disinfectant and allow to air dry. Do not blow on the site. Place the puncture device on the cleansed skin without compressing the tissue and activate the device according to manufacturer's instructions. Dispose of the device according to OSHA guidelines and your facility's policy. Performing a second puncture or double sticking is against the standards and should not be attempted. Wipe away the first drop of blood using a clean gauze pad, since this drop contains tissue fluid from the trauma of the puncture and may dilute or contaminate the specimen. Allow the blood to flow horizontally into a heparinized capillary tube so that no air bubbles enter the device. Do not milk the site to facilitate blood flow. When an adequate sample has been obtained, apply pressure to the puncture site and seal one end of the tube with a cap or other sealant. Place a metal bar or flea into the open end of the tube and quickly seal it. Move the metal flea with the magnet to mix the specimen to prevent clotting. Transport the specimen at room temperature. When collection is complete, elevate the extremity and apply pressure to the puncture site using a clean gauze pad until bleeding has stopped. Never leave an inpatient or dismiss an outpatient until all specimens are labeled with the patient's name, identification number, date and time of collection, and the initials of the collector as specified in your facility's policy. CLSI cautions against bandaging the heels of infants since adhesives threaten the integrity of delicate neonatal skin. Bandages also pose a choking hazard to the infant. Inspect the collection area, especially infant cribs and car seats, for supplies and equipment that might also pose a choking hazard. AARC suggests transporting the specimen on ice if testing will be delayed beyond 15 minutes. All individuals who collect arterial blood specimens should be aware of the complications commonly associated with the procedure, as well as the measures to take in the event of their occurrence. Patients who experience complications or adverse reactions should be promptly assessed and treated according to your facility's policy. Be sure to document the incident following your institution's incident reporting protocol. Due to the close proximity of nerves to both the radial and brachial arteries, arterial punctures may be painful to the patient. Should the patient experience an electric-like sensation, shooting pain, tingling, or numbness in the extremity, immediately remove the needle and apply firm pressure. These symptoms signal that the needle has provoked a nerve. Any additional movement of the needle or delay in its removal can cause further or permanent injury. Hematomas exert pressure on delicate nerve tissues and can lead to long-term complications. Always apply firm pressure to the area for a minimum of 3 to 5 minutes for radial punctures after the needle is withdrawn. 5 minutes for brachial and femoral punctures. Then release pressure and carefully observe the site for skin discoloration or a raising or mounding of the tissue, which indicates hematoma formation. If noted, apply 2 more minutes of additional pressure and check again. Repeat until bleeding has stopped. Notify the physician if hemostasis does not occur. Be aware that effective compression of the brachial artery is more difficult because of its location deep within soft tissue. Other complications include arteriospasm, infection, air or clot embolism, occlusion, and trauma to the artery. Every blood collection procedure carries the risk of the patient becoming nauseous or fainting. Signs to watch for include pallor, perspiration, hyperventilation, and anxiety. If the patient loses consciousness during the procedure, withdraw the needle immediately, apply pressure, and activate the needle's safety feature before assisting the patient. Notify personnel trained in first aid and, if practical, lay the patient flat. If the patient is sitting, lower the head below the plane of the heart. Avoid the use of ammonia inhalants, which may trigger respiratory distress. Allow ambulatory patients who experience dizziness or other signs of fainting adequate time to recover before releasing them from your care. Now let's review what we've learned about collecting arterial blood specimens. Identify the patient properly and explain the procedure. Gather necessary equipment and supplies and assure that the respiratory conditions have been constant for at least 20 minutes. Document the therapy or respiratory conditions. Position the patient and select the site, giving preference to the radial artery. Perform the modified Allen test. If positive, proceed with the puncture to the radial artery. Cleanse the site and allow it to air dry. For radial draws, hyperextend the patient's wrist. Perform the puncture, inserting the needle at an angle of 45 degrees or less, and allow the syringe to fill to the appropriate volume. Withdraw the needle and activate its safety feature or conceal the sharp immediately. Apply firm pressure to the puncture site for a minimum of 3 to 5 minutes. Cap the syringe. evacuate any air bubbles, and invert it according to manufacturer's instructions to assure adequate mixing of the specimen and anticoagulant. Carefully observe the puncture site for bleeding and hematoma formation. Once assured that bleeding has stopped, apply a pressure bandage. Be alert to signs of poor circulation in the extremity. For capillary collections, pre-warm the site. Cleanse the site and perform the puncture, wiping away the first drop. Without squeezing, collect the specimen into a heparinized capillary tube. Seal and mix the tube, making sure there are no air bubbles. Label the specimen and transport it for testing. When properly performed, arterial blood specimens yield valuable information to the respiratory therapist, nurse, and physician. Adhering to the standards for the procedure and your facility's policies is the best way to draw specimens that reflect the patient's actual respiratory and metabolic status while protecting you from accidental needle sticks and the patient from injury. We hope you found this video valuable and that you continue to apply the standards for the procedure whenever you collect arterial blood specimens. Because of the important role you play in patient care, your professionalism and expertise are critical to quality patient care. Thank you, and remember, accurate results begin with you. For information on other videos in this series, including basic venipuncture, preventing pre-analytical errors, avoiding phlebotomy-related lawsuits, and skin punctures and newborn screens, contact the Center for Phlebotomy Education. This has been a production of the Center for Phlebotomy Education, Incorporated, dedicated to providing educational resources on blood specimen collection to healthcare professionals around the world, and publisher of the Phlebotomy Today family of e-newsletters with over 10,000 readers worldwide. To inquire about our in-services and workshops, or for more information on products and services, visit our website at www.phlebotomy.com.